Is it recording? I wonder. Okay.
Yes, it is.
Okay.
Yes, it is.
Yeah. Okay, great.
Good. Okay. You can also hit from your end, just in case.
Actually, I went ahead and did that since I scheduled the meeting. Yeah.
Okay. Okay.
So now that we see that's good to go. So yeah.
Okay. So I'm going to start. Where are you? I know you can see me. Let me see my case. Oh. Okay. But you can hear me, right?
Yes, I can hear you fine.
Okay. I wish you could see me if I minimize my screen. Okay. There you are.
Okay.
Oh, yeah. You can see me now.
Yeah.
Okay. So this is the right case. Yes. MH is 65-year-old African-American female for a follow-up visit. She is wheelchair bound. She had a right heart cath lab last month. She is in the clinic for her ongoing symptoms of shortness of breath. Her pulse oximetry is 95% at room temperature. Her chief complaint is about ongoing shortness of breath. She has past medical history of atrial fib, CAD, constipation, depression, dyslipidemia, history of kidney stones. Assessment of disease. Since the patient is on warfarin, it is safe to assume that she has persistent AFib. Her cardiovascular assessment shows irregular rhythm. Over time, AFib can cause the heart to weaken and malfunction. The heart's ineffective contraction can cause blood to pool in the atria, and the blood can back up in the pulmonary veins, which can cause fluid to back up in the lungs, leading to fatigue and shortness of breath. Her objective assessment shows 1+ edema, which is considered to be very mild. All her labs are within limit, except her INR and PT values, which put her at an increased risk of bleeding. Her BMI is 37.3. She probably has sedentary lifestyle. She comes in on a wheelchair, and both are basically risk factors for CAD, and she does have a history of CAD. She had a right heart cath lab done last month, probably due to poorly controlled CAD. Assessment of current medications. Can you hear me okay, Marcia?
Yes. Yeah, I can hear you fine.
Okay. So assessment of current medications. She is on Bisacodyl and Docusate, which are both for constipation. She's on tamsulosin 0.4 milligrams, probably for bladder obstruction. She's on furosemide 20 milligrams QD as needed for possible edema. She's on metoprolol succinate 25 milligrams, which is a beta blocker, and she has a history of CAD, so they are considered to be first line for the treatment of CAD. She has paroxetine for depression, simvastatin for hyperlipidemia, and warfarin for anticoagulation. Dosing of beta blockers in CAD targets 50 to 60 beats per minute. Her rate is 69 beats per minute. Her blood pressure, lipid profile, and light for her latest labs are WNL. And now I'm going to go on to a treatment plan.
Okay.
Keeping in mind that her chief complaint is SOB, shortness of breath.
Okay.
Ongoing shortness of breath. Okay. So her objective assessment shows irregular rhythm, and her chief complaint is of shortness of breath. So I believe an antiarrhythmic should be introduced to help control her AFib. So she's already on warfarin, and she's also on metoprolol, but because of her irregular rhythm and SOB, I plan to introduce another AFib medication. And for people with CAD, the guidelines recommend the use of sotalol or dronedarone. In this case, sotalol is contraindicated because her creatinine clearance is only 33.6, and it's contraindicated in people with less than 40 ml per minute. In patients with permanent AFib, per ACC guidelines, dronedarone increases the combined endpoint of stroke, cardiovascular death, and hospitalization. So I'm not in favor of using dronedarone on this patient because I'm not sure if she has persistent or permanent AFib. I would suggest using amiodarone for this patient, as according to these guidelines, it is the most effective agent in maintaining sinus rhythm in patients with paroxysmal or persistent AFib. In patients with CAD, it is associated with low risk of proarrhythmia, making it an appropriate initial choice. The suggested dose for amiodarone would be 400 to 600 milligrams daily in divided doses for 2 to 4 weeks until a total dose of 10 grams has been given. And then we will go on to a typical maintenance dose of 100 to 200 milligrams daily. Amiodarone has a lot of drug interactions, and MH is on warfarin. The dose of warfarin needs to be decreased by 33 to 50% when adding amiodarone. Since MH has CAD and is less than 75 years old, I would also recommend to put her on a high-intensity statin. I would like to switch her from simvastatin that she is currently on to atorvastatin 40 milligrams q-day. Her HDL is 40, which is at the lower end of the HDL ranges. That's also another reason I'm trying to switch her to a high-intensity, statin. She's also on paroxetine for her depression. Both amiodarone and paroxetine are QT prolongation agents, so her QT interval needs to be closely monitored. Her CHAD-2 VASC score is 2+, which means the stroke risk of 4% or greater annually. So her risk of stroke is more than her risk of bleeding, so she needs to be anticoagulated. She's already on warfarin, but her warfarin dose needs to be adjusted because of the addition of amiodarone, and also her latest labs show higher PT and INR values. All other medications will continue as before. So basically, we are introducing amiodarone and we are introducing atorvastatin in place of simvastatin. Monitoring plan safety. MH needs to be monitored for blood pressure, heart rate, and periodic EKG. Close surveillance of heart rate is especially important during first week with amiodarone. Baseline PFT, pulmonary function tests, are required, and then periodically, because amiodarone can cause pulmonary toxicity. TSH is required at baseline and then again periodically. She is also supposed to get periodic fasting lipid profile and CMP. Ophthalmic exams are recommended because amiodarone can cause corneal deposit. LFT needs to be done at baseline and every 6 months, as we are putting her on high intensity statin to monitor the newly introduced statin, the Lipitor. I would recommend an LFT at 12 weeks this time to see the effect of atorvastatin on her lipid profile. Periodic INR and PT labs are definitely required due to the warfarin therapy, and they can be stabilized to every 2 to 4 weeks lab. Next is monitoring plan efficacy. Periodic EKG will be a good indicator of the AFib control and the QT interval, which could be increased because of paroxetine and amiodarone together. I would recommend MH getting an EKG quarterly. Improving of symptoms of shortness of breath will be a great sign to show the effectiveness of amiodarone. PT-INR values will help indicate that the warfarin levels are within the reference ranges. I'm going to move on to patient education. Educate the patient about the importance of coming in for regular lab draws, importance of having periodic EKGs. The patient is supposed to report any signs and symptoms of weight gain or worsening of SOB. To avoid dizziness and passing out when on amiodarone, rise slowly over a few minutes when lying or sitting. So basically, yeah, so just rise slowly to prevent, the dizziness. Also avoiding grapefruit juice while being on amiodarone, and call the clinic to report any symptoms of bradycardia, especially in the first few weeks of starting treatment with amiodarone. That should be all for me.
All right. Very good. You were perfect, exactly at 10 minutes.
Oh, really? Wow.
Yeah.
I didn't know that. I was like, oh, I'm too short. I thought I was too short.
Nope, you're right on.
Good.
Okay. And so you were saying the amiodarone, you were going to start at 400 to 600 total daily dose in divided doses.
400 to 600 milligrams divided doses till the loading dose of 10 grams is achieved. And then we would step down to 100 to 200 every day for maintenance.
Okay. And then, all right. And then you're just going to maintain her warfarin as her anticoagulant.
Yes, because she's pretty used to it and, it has been agreeing with her. So I don't see any reason to, introduce a new anticoagulant for her.
Okay.
But we do need to adjust the dose, which I said it has to be decreased by 33 to 50%.
Mm-hmm. Okay. All right. Well, that was good.
Oh, thank you.
That was easy. All right. And was there any dose adjustment for her renal impairment with the amiodarone?
Okay, with the amiodarone, no. I could not put her on sotalol because that's contraindicated for people with creatinine clearance less than 40. But she has 33 point something. Mm-hmm. So that should be okay with amiodarone, yes.
Okay.
But sotalol is contraindicated, yes.
Okay. All right, great. Now let's see. Okay, so yeah, I don't know if you want to take notes for the rubric while I do mine, because when we're done in Canvas, we have to do our peer review. So
right.
So that's what I was doing. I was just jotting down notes. So
yeah. So when you present your case, I'll do my notes, and then I will load up the rubric in the discussions.
Okay, great. Yeah. All right. And then do you want me to send you a copy of my case again?
Yes, I do, because I think that would help me with the rubric a lot.
Yeah. Okay. Yeah. Let me
yeah.
Send you that.
Yeah. And you got mine, right? You already got mine, yeah.
Yes, except yes. I don't know.
I can post it in the discussion.
Yeah, I might post it in the discussion as well, because
yes.
My thoughts are that the rubric is based on the verbal presentation and not, the paperwork that we, have done. I'm not sure. We might have to, clarify that with Leisha, or
Because I think the verbal presentation is going to be very much in line with whatever I've written.
Sure.
So I think for me, it's going to be pretty exactly same.
Yeah.
Because I exactly read off my case.
Okay.
What I prepared, you know?
Yeah.
Yeah.
All right. Well, let me send you.
But I will definitely send you this case in the Canvas. So, you know, it's easy for you to do the rubric. Yeah.
Okay. Let's see.
Yeah, I'm going to post it in the discussion thread. Yeah. Even for the professor to see too. Yeah.
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 Okay. Whoops. Okay, there's case 2. Okay, it's not let me do it that way. 1 second. Okay, open and open. And here's the rubric. Oh. Okay, I just sent you everything in Canvas.
You did? Okay. Yeah, I'm trying to post mine too.
Should be 3 attachments.
Is it in the discussions or where?
No, it should just be like your regular inbox.
Oh, inbox. Okay, this is in the inbox. Oh yeah, I see it. Okay.
Okay.
Okay, that's fine. And I can actually mail you through the inbox too.
Okay.
Afib case rubric. Okay.
Yeah.
Okay.
All right. Okay, so I will go ahead and get started here. I have AG, and she's a 73-year-old Caucasian female, and she is at an acute visit at her PCP with feelings of palpitations, like her heart is jumping out of her chest. She has a heart rate of 52, and she reports shortness of breath, fatigue, and weakness over the past 2 weeks. Her EKG findings are indicative of substantial left ventricular hypertrophy and atrial fibrillation. And this is a new onset and persistent AFib, defined as sustained more than 7 days, since she described it as over 2 weeks' time. And the supporting evidence of this diagnosis, starting with her problem list, again includes the heart palpitations, heart rate of 152. Her blood pressure is 134/86. She has, again, the shortness of breath, fatigue, and weakness. 1+ edema, which is mild. Her history and risk factors for disease include increasing age, hypertension, type 2 diabetes, and obesity. She's 200 pounds and has a BMI of 34, and her height is 64 inches. Her CHA2DS2-VASc score is 4, which is translates to an annual stroke risk of 4%. And she does have renal impairment. Her serum creatinine is 1.87, and her estimated creatinine clearance is 35.7 mils per minute. Her current medications for hypertension are amlodipine, furosemide, and lisinopril. She takes simvastatin, 10 mg per day for hyperlipidemia, and she takes a daily baby aspirin, Novolog, Lantus, and Zolpidem, 5 milligram, as needed at bedtime for insomnia. Based on her medication regimen, I feel that her blood pressure is, since it is controlled, that she's been adherent to her antihypertension regimen. Her A1C is 6.6%, which I also think is indicative of adherence to her insulin regimen. However, her HDLs are low at 38, and her triglycerides are high at 168, so potentially simvastatin therapy may be inadequate. So her treatment goals are to restore normal sinus rhythm and to provide symptom relief, and also prevention of any recurrent atrial fibrillation events, stroke or systemic embolism, tachycardia-induced cardiomyopathy, and improve her survival rate. For her treatment plan, I want to add therapy for AFib and rate control, and I also want to change her current therapy for safe and effective use of her rhythm and rate medications, and also to meet her goals for hyperlipidemia. So I'm going to discontinue her simvastatin because of the dosage limitation of the 10 milligrams per day during concomitant use with dronedarone, and because her dyslipidemia is uncontrolled. And in place of simvastatin, I'd like to start atorvastatin, 10 milligrams daily, and hopefully see some improved lipid response. I also want to discontinue the amlodipine and switch her to a non-dihydropyridine calcium channel blocker, also for her AFib and rate control, and replace the amlodipine with verapamil ER, 180 milligram orally daily. This will be her non-dihydropyridine calcium channel blocker. Then for her pharmacologic AFib cardioversion, I want to start her on dronedarone, 400 milligrams orally twice daily. And I chose dronedarone because not only will it reduce her resting heart rate approximately 12 beats per minute, but it will also improve her heart rate during exercise. And she did express that she was exercising regularly prior to experiencing these symptoms for that 2-week period. And also because dronedarone does not require a dosage adjustment with renal impairment. Then she does qualify or meet criteria for anticoagulation. So I'd like to initiate apixaban, 2.5 milligram orally twice daily. This should reduce the incidence of ischemic stroke. And the criteria that she met is a CHADS VAS score greater than or equal to 2. Monitoring her efficacy plan for dronedarone and verapamil. We'll be looking at her meeting her goals for blood pressure, heart rate, and ECG and rhythm. For Lipitor, we're going to see if she meets her target lipid levels, or at least within normal ranges. So I want to do a baseline lipid panel, a fasting panel at 4 to 12 weeks after initiation or dose adjustment, then every 3 to 12 months as warranted. I'm also starting on her on a low dose of atorvastatin, and we can titrate as warranted because her triglycerides and her HDL weren't severely out of range. So I don't think she needs as aggressive therapy. For apixaban, we don't have to monitor. The advantage is that we don't have to monitor PT-INR or APTT. However, if you do monitor them, they will be elevated. Also, if you need additional guidance for therapy changes with apixaban, you can look at plasma concentrations of anti-factor 10A activity, which should have a linear relationship with her anticoagulation. For her monitoring plan safety, dronedarone has multiple potential adverse events, serious adverse events, and drug interactions. We will look at her blood pressure, heart rate, and rhythm, monitor her ECG approximately every 3 months, and also look for potential QTc interval prolongation. and look for any new or worsening signs of heart failure, such as edema or rapid weight gain or worsening of shortness of breath. For her atorvastatin, she's at increased risk of myopathy and myalgia and rhabdomyolysis, and potentially excessive LDL reduction. So we'll monitor a lipid panel 2 to 4 weeks after dose initiation or adjustment. And if she has 2 consecutive LDL levels less than 40 mg per deciliter, we can consider a dose reduction in the atorvastatin. Dronedarone, verapamil, grapefruit, and grapefruit juice all interact with atorvastatin and can increase the exposure of atorvastatin. So we will also be looking and using the lipid panel monitoring for the interaction there. Furosemide and dronedarone can also interact and cause a hypokalemia and a hypomagnesemia. So we will monitor serum electrolytes prior to initiation of dronedarone and frequently for the first few months and then periodically thereafter. As well, dronedarone and verapamil potentially have a drug interaction of increased exposure of either agent. So again, we'll just be watching for blood pressure, heart rate, ECG, and rhythm, and worsening of, or new onset heart failure. Her verapamil can possibly cause negative inotropic effects, so we would look to monitor for left ventricular systolic dysfunction, or in other words, a decreased ejection fraction, and we'd consider discontinuing verapamil if that occurred. And apixapan, monitoring, of course, for bleeding, signs and symptoms of bleeding, and any additional renal impairment. So we want to do renal function evaluation prior to starting, and then clinically thereafter, and at least annually. Also hepatic function, signs and symptoms of bleeding, which will be reported by the patient. And for her patient education, we want to encourage her to continue her walking 30 minutes 3 times per week. Encouraged her to reduce her saturated fat intake, like cheese, fried foods, fast foods for her triglycerides. Avoid grapefruit and grapefruit juice when she takes her dose of atorvastatin or dronedarone. To report any unexplained muscle aches or pains. Report any unexplained weight gain or swelling in her hands, legs, or feet. Changes in her heart rate or shortness of breath. Any loss of appetite, fatigue, yellowing of skin or dark urine, nausea or vomiting, or abdominal pain may be indicative of dronedarone toxicity with these symptoms to the liver. And then signs and symptoms of bleeding, such as bruising easily, bloody nose, or cuts that don't clot quickly. And then also to continue her medications and do not stop taking her medications without talking to her doctor. And that is everything.
Great. Sounds good.
How long did I go? Do you know?
No, you know what? I don't.
Oh, that's okay. I didn't.
Yeah, I didn't look. But I think you should be okay. I think you should be okay.
I think we did because it's only 6:30, and we both finished.
That is 5:30, and so 25 minutes for both of us. Yeah.
Yeah.
We should be okay. And we were talking in between. So
yeah.
Yeah.
So any questions for me?
I think when you're moving from simvastatin to atorvastatin, 10 milligrams a day, which is not really a high intensity dose.
Correct.
But you still would like to do that?
I would like to do that because if you look at her her labs,
I heard you.
Yeah, there. The range for the HDL is 40 to 60, and she's at 38. And the range for her triglycerides is 0 to 150, and she's 168.
168.
So she's not. She's not, severely, above the upper limit normal ranges, and we always have the means or the time to titrate upwards. So, so because of that, because of those two things, that
Yeah.
she doesn't have severe dyslipidemia enough, I think, to warrant starting at higher dose. I don't see any reason why we can't just start her at the lower dose and titrate as clinically warranted. And also her age, although I think at 73 these days, that's starting to not be that old anymore.
No.
But yeah, so I don't think you can. In this case, I think start low and go slow is conservative, and it's not an emergency acute agent of treatment.
Right. Oh yeah. Yeah.
That would be my justification.
And other thing is, I'm not the Lipitor with grapefruit interaction.
Mm-hmm.
I think that's very, what do you call it? It might be fair, but not, the reliability is very, like, it's not that to worry about, It's the reliability is, I think it's fair, but not, how you have it's fair, but it's not well documented. Yeah. Just FYI, I'm pretty sure, like, when Lipitor came out, like, say 15 years ago. Yeah.
Yeah, you know what? I checked those actually because if it was low, like moderate to low, I probably wouldn't have included it. But
because that's what, but again, I can look at it, no worries. That's not a big deal, it's not a big deal. It's always good not to drink grapefruit juice. But I remember, like, back in those days, this was, like, had a very fair but low reliability, in the drug interaction. But it's okay. It's not a big deal. Yeah, that's not a big deal.
No, go ahead.
And then, what was my question? I should have read the case, but left ventricular hypertrophy and the AFib, was it given to you, like, in the case, right? This was given in the case. Okay.
Yes, it was. That was the EKG finding.
Okay, the left ventricular hypertrophy and the AFib.
Right.
Okay.
Yeah, correct.
Okay, cool. Yeah, I was like, okay, good, great. You know what? I think looks good to me. I mean, I can definitely see the written part, and then,
Okay.
And then do the rubric after I see the written portion,
Yeah.
It will help me bring it together,
Okay.
Yeah.
Yeah, actually, so let's see. I was just, while you were talking, I was looking at, so in micromedics, the grapefruit and atorvastatin is considered a moderate drug interaction.
What about the reliability?
The reliability documentation is excellent, it says. Concurrent
really?
use. Yeah.
Let me look at the lexicon, because I always use Lexi. Let me look at Lexi. Because it's weird.
Yeah.
That's good. That's good to know, because I remember, like, this was back in those days, many, many years ago.
Yeah, and so of course, the literature would have accumulated by now, and
let me see.
Yeah, what does Lexi say?
It does say reliability excellent. Yes.
Oh, cool. Okay, great.
But wow, that's weird, because not much counseling is done, I believe, for Lipitor. I know for others we do, for other statins.
Yeah,
something to think about. Something to think about.
Yeah, I think sometimes you kind of
overlook it,
or
because
they go to the wayside.
Major, that's weird. Good. I'm glad you brought that up.
Great.
Because I was mainly focused with simvastatin on the grapefruit juice, but great,
Sure. Yeah.
I think it's maybe the pravastatin, which doesn't have any interaction with grapefruit, I believe. It might be pravastatin. Okay.
Okay. Yeah, it's helpful just, when we do these things, that just sheds new light on things that we haven't thought about for a while.
Right.
Yeah.
No, great, thank you. And I think, I guess that's all I have.
Okay.
Yeah.
Okay. Well, I can I created a file to capture our recording, so I'll upload it
Okay.
and send it to the powers that be. Whoever
You're
looks
going,
at it, I'm not
you're
sure.
going to, you're going to put it in the discussion, right? I mean, in the discussion.
I'm not sure actually, because I copied I downloaded the instructions for let's see, uploading into Canvas, so it will go into Canvas.
Canvas
I guess I can
where
just upload it right in that
the
same
discussion.
discussion part. Yeah.
Right. And because I am planning to upload the rubric in the discussion too.
Okay, sounds good.
Sounds great?
All
Okay.
right. Well, I'm glad we got it done.
Yeah, finally.
Now we don't have to worry about it.
I know, and I can focus on my finals.
Yeah,
On my midterm.
I know. Me too. We can
Oh, I
got it
know we
off our
can.
plate and we can study for the cardiovascular
I know,
test. So.
man. Yep. Great, Marissa. Thank you so much.
All right. Thank you. Have a good evening.
You too.
Okay.
Bye.
Bye-bye.
Bye.